脏病高危患者运动训练是由来自欧洲心脏病学会预防心脏病学方案委员会的现任主席、瑞士的波恩大学的教授在咱们做演讲。Now, warmly welcome Professor Jean PaulSchmid from Foreign University, Switzerland.
Thank you very much. Dear Chairperson, dear colleagues, thank you for the very kind invitation also. It's the second time I am here and I have the opportunity to talk to you about a specific topic in cardiac rehabilitation, which this time is cardiac rehabilitation in high-risk patients. High risk, probably, if we talk about high risk, it is about heart failure, but sometimes other problems can occur which is not only related to left ventricular function. Now, if we talk about training, rehabilitation, we also mostly talk about exercise. And I just want to stress the point that rehabilitation, if you talk about rehabilitation, it is always, should be multidisciplinary. So it is not only about exercise. Exercise is a core of the rehab, but it should be multidisciplinary. And you see that we know that from the other slides we have seen today that the recommendation of rehabilitation and exercise in heart failure patients is class 1 level A evidence, so there's very good multi-center trial evidence about exercise, but also the multidisciplinary point. Now, when we say multidisciplinary, what should we talk about? If we say multidisciplinary, it is also that we have specific standards within a program, which is the organization of the assessment of the patients in the hospital, and then to send the patients to the rehab clinic also. So it has to be well organized, it has to be a system within there, and this allows then the best outcome for the patients with all the components of cardiac rehabilitation we normally know. Now, what is important, if we talk about high-risk patients, it is to determine what is the risk in a patient. And I tell the fellows, you have to get a picture of your patient. You have to know what is his risk, and there are some criteria with which you can judge the risk. For example, if you see a patient who has a functional class, New York Heart Association class 3, he has an elevated BNP, he has an extended coronary artery disease and hypertension, ejection fraction is 25%. The echo shows you a restricted filling pattern during diastole. The left ventricular diameter is increased. He has a severe mitral regurgitation as well as a tricuspid regurgitation, and the right ventricle is dilated. He has an elevated pulmonary pressure, and he has a low exercise capacity and a high VeVCO2 slope. I mean, this is a high-risk patient. And if you see these values, then you know you have to be very cautious training this patient. And if you have a patient who has not all these very important risk factors, then it is a little bit another story. So make you a picture. The assessment, the initial assessment is very important. When we talk about high-risk patients, there are different types of patients. We can have the post-acute myocardial infarction patient. This is a patient who has some kind of risk of arrhythmias. He has probably, if he is high risk, reduced ejection fraction, and these are the main problems in this patient. You can have a patient with chronic heart failure. Then you know that probably his problem is not the acute event. This is another picture of this patient. He has probably decreased exercise capacity, decreased left ventricular function, but it's a little bit different from the post-acute myocardial infarction patient. Then you have patients with a condition after cardiac surgery. In these patients, you can have the complications of surgery. You can have a post-cardiotomy syndrome, you can have pericardial effusion, you can have anemia, bleedings, and so on. So this is another risk profile. So this is another picture again. And then you have patients with valvular heart disease. Here also, these are patients with post-surgical complications, but also you know that these patients can have AV conduction problems. So this is another risk of the patient. And this underlines the importance that you have your picture of your patient. You know, is it a post-acute MI patient? Is it a chronic heart failure? Has he had surgery? Which are the complications? This is very important. When you know this, then you have on the one side the risk associated with the baseline disease, and then other risks associated with comorbidities. So has this patient renal failure? Has this patient COPD? What is his oxygen saturation during exercise? So this completes your picture and gives you an image of your high-risk patient. Now, what is special in high-risk patients? What differ high-risk patients from the ordinary one? Of course, first of all, this is the reduced exercise capacity. So these are patients who are not able to train very well, which has to be taken at low intensity. And this is not a risk in itself, but it shows you high risk in general is low exercise capacity, and accordingly exercise prescription has to be adapted. Certainly these patients require more intensive medical supervision. If you have the example of the first patients, it's sure you have to see this patient every time he goes to exercise. You have to be sure that he is compensated, that his pulmonary auscultation is good, he is not in a pre-lung edema, to be sure that he has not arrhythmias, new arrhythmias, and you have to evaluate his progress very often. I mean, a patient who has few symptoms, who progresses, who does better during exercise, he's doing well, even though he has high risk. If a patient is not progressing after 3, 4, 5 weeks, although he's well training, you have to ask yourself, what is the problem behind? There's something is going wrong. And the frequent problems which occur are hypotension. You can imagine these patients with low ejection fraction on diuretic therapy, hypotensive, and not very well. So sometimes you have to interrupt cardiac rehabilitation, optimize medication, or optimize the diuretics to improve hypotensive symptoms. Dyspnea, if you have lung disease in particular, is very difficult in these patients to do exercise, but you just try to make what is possible. You stay at low intensity and you always follow the symptoms of your patient. What he's able to do is right. When he gets more dyspnea, then you have to go down with the exercise intensity, and fluid homeostasis, as said, is very important, and is in particular also the problem of hypotension linked with fluid elimination. Now, when we talk about high-risk patients, of course, in these patients you have to have the best assessment which you have at your disposition. We talked about echo in these patients. In some post-acute MI patients, you not necessarily need to do an echocardiography when they come to your cardiac rehabilitation institution, but for high-risk patients, I would really recommend it to see whether there are post-surgical complications, what is ejection fraction, which is the importance of mitral valve regurgitation, etc. You have to complete your laboratory values. And then cardiopulmonary exercise testing. is really something which gives you a lot of information, not only about information about exercise prescription, but it also gives you information about the severity of the disease, and I will show you that in a moment. But just to have mentioned what is important, you have the exercise capacity in itself, then you have the ventilatory efficiency, which is reflected by the VE/VCO2 slope. The higher it is, the more serious is the disease. And then the periodic breathing, which is also a sign of very severe disease. And finally, we always have to ask ourselves if we have patients with low ejection fractions, whether they improve, whether ejection fraction improves, and if this is not the case, whether these are candidates for an ICD implantation. So this is just to give you an example how cardiopulmonary exercise testing shows you the severity of the disease. In this patient, he has kind of an oscillatory ventilation. Normally this is straight away, this ventilation, but it is kind of oscillative. You see it also here. This is kind of change-Stokes aspiration, which occurs in advanced heart failure. If you see this, you know this is high risk. This patient also has a chronotropic incompetence. Well, difficult to train these patients to make exercise prescription. You just follow the symptoms. Then you see that the oxygen pulse, which reflects the ventricular function during exercise, is reduced. You see that exercise capacity is very low, below the maybe, let's say, 50% of predicted value. You see this very elevated VE/VCO2 slope. Normally it should follow here this line, but this is very much increased, which shows you a mismatch between ventilation and the circulation, and shows you a patient who has probably kind of pre-edema status. He has a very early first lactate threshold, which means that the muscle function is very reduced, and he has a pulmonary comorbidity. You see that he's unable to increase his respiratory volume, his tidal volume very much. He's doing everything he can just by increasing the ventilatory rate, the respiratory rate. So cardiopulmonary exercise testing completes your picture of a patient of high risk. Now, exercise in high-risk patients has, on one hand, the point that we would like to have very much of benefit, because these patients are the most severely diseased. So we would like to improve exercise. We would also like to improve remodeling. We know that exercise in post-myocardial infarction is improving remodeling. It is not doing any harm, so it's important to start early. We know the effects at long term on slowing down of atherosclerosis, and we know also that exercise improves quality of life, morbidity and mortality in the setting of cardiac rehabilitation, once again, which is multidisciplinary. And on the other hand, what are the risks? The risk is the risk of negative remodeling. I would say this risk is very low. Data show that left ventricular function improves with exercise and the diameters come down. Arrhythmias during exercise are very rare. We have heard it also today that exercise in itself is not a very high risk. It is more the baseline disease which is of risk. And cardiac decompensation with exercise is also almost not possible. So the risks, even though the patients are at high risk, risk of complications are very low, and everything is about the assessment of the patient and then the prescription of the low intensity adapted exercise capacity. This is a very long vicious circle of the inactivity in heart failure patients. You have at the start the systolic dysfunction, whether this is cardiomyopathy or myocardial infarction, and you see what is happening. coming down at the catabolic state, skeletal muscle atrophy, respiratory muscle atrophy, the increased ergo-reflex activity, sympathetic activation, all these negative impact of a reduced ejection fraction. And we know that exercise is doing very well in all these points. It ameliorates the catabolic state, so it increases muscle mass if you do it well. It increases skeletal and respiratory muscle. It improves the ergo-reflex. It decreases sympathetic activity, and it is a kind of vasodilator treatment. So very important to have this exercise treatment modality in these patients. The question is then, how can we improve systolic dysfunction? There are some data, we have heard about that high intensity interval training can improve ejection fraction. As we have heard also is that probably it is not for all patients, but heart failure patients which are in a good functional state, they can do high intensity exercise and probably they can improve LV function. They are candidates for CRT. CRT is also something which is very well improving ejection fraction, especially if combined with training program. Then we have resistance training and inspiratory muscle training, in particular to improve skeletal and respiratory muscle atrophy, and then the endurance training, which is more working on ergo-reflex and sympathetic activation. Now, this shows you the complete picture of rehabilitation. Sorry, this just not following. This one. Yes. Next one is missing. Well, we miss one slide. We should try to restart it, but next one, please.
You want to show this one?
No, this one. This one is not coming.
他说这也没有出来，他摁的时候没反应。
This one. Okay. Okay. So we're here. Okay. One question about safety in high-risk patients is the question of monitoring. Shall we monitor patients when they are doing exercise with the ECG? And when we look at the recommendations say that in high-risk patients at the beginning it might be very useful to have some kind of monitoring, because it gives you some hints about how they improve during exercise, whether there are arrhythmias, and it is very useful. Of course, we know that doing monitoring during endurance training is very easy. We can have the ECG, however, when we do respiratory muscle training or resistance training, it's more difficult. So you don't have to monitor all the time your heart failure patients. However, during some time, during exercise, it can be useful, and especially when starting. And ECG is one, but what is sure is that you have to look at your patient's physical examination, blood pressure response, and the heart rhythm are very important points to look at when you have your patients during exercise. This is an example of a patient who is starting exercise. He feels a little bit tired, more tired than the last days. Borg scale during training is higher than usual, and you see this typical scattering of the heart rate with a heart rate which is around 135 to 150 during exercise. And you know that if you look at the monitored ECG, that this patient has developed atrial fibrillation, which also has to be treated. You have to look whether the patient is on anticoagulation or not. This is not a patient with some newly shortness of breath. And if you look at his recording of you see the training here, and you see his heart rate just a little bit lower than 150. And as you expect on the ECG, you see here frequent P waves in the patient with an atrial flutter, or this patient who has had sudden cardiac, who reports sudden weakness and slight oppression on the chest. You see that he has a very strange behavior of his heart rate. He had to lower his exercise intensity because he did not feel well. He had this sudden weakness, this oppression, and if you look at the ECG, you see that all of a sudden he has small ventricular arrhythmias, which you detect with monitoring and which you would not if you don't have this. So I think it is important to have this opportunity to monitor patients at starting of exercise until you know that they are doing well, and tailor exercise as we have heard, and make you really a picture of the complicated case of your patient, whether it is at very high risk or not. If you want to know more about how to do exercise, not only in high-risk patients, but also in low-risk patients, how to improve best exercise capacity, how to perform resistance training, how to perform respiratory muscle training, I would like to show you this picture of our course of this year's international course on cardiac rehabilitation and sports cardiology, to which you are invited also if you are able to join us. We do this course on the 20th to the 23rd of November this year. It is an international panel, and it's a course on 4 days. And just to show you what we are talking about, it is on Thursday, it is on heart failure, which is state-of-the-art, then evidence of the rehabilitation, then stress testing, multidisciplinary approach, exercise training in high-risk patients, what you talked about, and then exercise in special exercise modalities. And on the other days, you see that we have kind of an overview on cardiac rehabilitation in general, what are the principles. Then there is a day on sports cardiology, and we try to cover everything which comes from the theory to exercise testing to exercise prescription in this course on 4 days. And we know that some of your colleagues have already attended this course, and maybe you have the opportunity to join us this year. I thank you for your attention.
Thank you for your great presentation. Any comments and questions from the audience? Okay, I have 2 questions for you, Professor. The first, how often will you re-evaluate the patients and adjust your prescription? Second, do you always monitor the whole course of rehabilitation training for the patients by a doctor or by paramedical staff only?
Okay, so the first question is about the re-evaluation. It's a good question. We don't do it regularly. I think it is good to have a picture at the beginning, at the start. You have your exercise test and you do the prescription, and thereafter to increase the intensity, the physiotherapists in general know very well how to do. So I don't think you need after some weeks to retest and do then another new exercise prescription. Following the patients, increasing the resistance, increasing the intensity, following the symptoms of the patients is enough, I think. And the second question was about the monitoring of the patients, whether we do it all the time. Yes. So I think you don't have to do it all the time. As I said, there are some training modalities where it is difficult to monitor. And then the question whether there have to be doctors or not. I mean, people who are looking at the ECG have to have some idea about what is wrong and what is okay. They have to know what are extrasystole, if they are normal or not, what is atrial fibrillation, and so on. So you need to have a certain knowledge of the ECG, which must not be very complete. So it must not be a doctor, but there needs to be a certain knowledge, and just to know that if a heart rate is all of a sudden 30 beats more than normal, then they have to call the doctor, or if the ECG is getting broad, then something is wrong and they have to call the doctor. Yes, but can also be other people.
还有2分钟的时间，大家可以借着刚才4位报告者有什么问题，还可以再提。有什么问题也可以再讨论。好，先。
好，我想提几个问题第一个问题是我想问一下高老师老师您刚才在讲的时候提到了药物的治疗，我想问一下，现在就是运动康复比较火嘛，就是您觉得就是运动它是作为一个就是辅助的疗法来促进运动康复呢，还是对于一些并非很严重的心血管的疾病，我们可以不用药物，用运动来代替它的一种自然疗法比较好的？比如说，我想这个问题你自己就能回答。心脏病的病人可以光运动不用药吗？就是一些，比如说一些冠心病，它当有一些轻微的那种感觉，比如说胸闷啊，或者是气短，然后它并没有一些特别严重。我的前提是它并不是特别严重，但是你想，如果一个高血压的病人，他通过服药的话，也是药物也有半衰期，对吧？但是运动的话，它也是可以起到一个这种在这个过程中治疗的作用当然它这个可不可以作为一种自然疗法来和运动和那个药物作为那个什么？
我先来直接回答你吧。这个运动和药物治疗是心脏病包括高血压治疗的一个相辅相成的2个方面。它在治疗的过程当中，比如病人像我们一些危险因素，像高血压病人可能有时候比较偏胖缺乏运动的，你让他加强运动，或者我们这个有计划有辅导的这种心脏的康复，病人的很多危险因素可以得以控制，他的血压的控制要比平常要容易得多。那么，所以在这个治疗过程当中，我们需要根据病人的反应来调整药物，这是对于药物的这个运动对于药物的这个影响。那么，不管是什么情况，如果病人诊断了冠心病，他的一些规范的2聚防用药就是必须的，而且必须达标的。所以我们不能强调说病人做运动就把药都戒了，那是巫医，那不是我们推荐的心脏康复。所以2个方面哪个都不能偏颇，但是呢，所有的都应该是按照规范去做。那么刚才也提到了，你运动其实也是根据病人的情况，可能刚开始运动量没有很大，我们做了评估，他的运动量没有很大，随着运动的增加，他的适应性在增强，病人的健康状态在改善，你的运动可以逐渐的增加。这个过程当中有一些，比如改善心绞痛的药、降压的药，可能就会减少。但是他汀、阿司匹林、抗血小板的药物这些你是不可以停的，但是它的用量 你是可以根据病人的具体情况进行调整。所以我们为什么宣传心脏康复？它一定是是一个综合的治疗，是以运动为核心的一个全面的心脏康复，不是单纯的把运动和药物治疗给它，包括现在很多人把它跟介入治疗对比起来。我觉得所有的治疗都应该是一个整体，不应该是对立的。谢谢。谢谢老师。Questions?
Yeah, I want to ask Professor. Okay, I have. Thank you. You have said about resistant exercise. I think maybe now it's very controversial about the resistance on the effect of resistant exercise on the cytopenia. Maybe the resistant exercise they have some negative effects on arterial stiffness. So I think I want to ask you how to see this question. Yeah.
Yes, long time ago, it was considered really a contraindication in heart failure to do resistance training. But now, it's something we know that if it is well performed, like I told you, with some careful and with some kinds of training, you can get benefits, and it's not harmful, especially if you combine with the other kinds like aerobic training. I told you that you have to do some groups of muscle, not all muscle at the same time. You have to avoid ensemble maneuver during the training, and it has to be something also progressive and adequate to your patient, the intensity of the resistance training. So if you do like that, you don't have the risk of increasing blood pressure and of decreasing the systolic ejection volume. It is proved. You just have to do it right, and it is proved it has benefits and that the risk is controlled risk. Okay, thank you very much. Thank you for the question.
好的 ，Thank you for our speakers。那个今天那个第一个 section 的时间到这儿结束，那个大家去 break。那我耽误了一点时间，还有8分钟，可以大家就回来继续第二个 section。好，谢谢大家。
现在都是要有证据啊，都是有 evidence。
在下面，下面的吧，好像啊，下面好像，下面也这么一帮人。
没事，可以。
你们先下去。
好，先走，1、2、3，开吧。